Ms Neild.
Thank you, my lady. I'd like to call, please, Professor Habib Naqvi, who will affirm.
I do solemnly,
sincerely and truly declare and affirm that the evidence I shall give is the truth, the whole truth, and nothing but the truth.
Can you give your full name, please?
Professor Habib Naqvi.
Now, Professor Naqvi, you have given a witness statement to the inquiry dated the 13th of October 2023. That's INQ 000315-604. I think you're familiar with that statement and you have a copy in front of you. Is that right?
That's correct.
Professor Naqvi, you are the Chief Executive Officer of the Race and Health Observatory. Is that correct?
That's correct.
And you have been so since its inception in April of 2021.
That's correct.
I think previously you worked for NHS England, where you directed the development and implementation of national programmes, including the Equality Delivery System and the NHS Workforce Race and Equality Standard. And prior to working for NHS England, I think you worked at the Department of Health and Social Care, where you led on national equality and diversity policy. Is that right?
That's correct.
The Race and Health Observatory, I think, was established during the COVID pandemic in April 2021, but that wasn't the reason for its creation. What are the purpose and aims of the observatory, please?
The observatory's purpose and aims are to identify and tackle ethnic and racial inequalities in health by focusing on some of the deep-seated issues within the healthcare system, but also within the social determinants of health as well.
And I think whilst the observatory works closely with and receives funding from NHS England, it is an independent body, is that right?
Absolutely. It's an independent organisation that can hold up a mirror to the rest of the healthcare system and act as an excuse remover.
And you explain in your witness statement that the work of the Race and Health Observatory is not only focused on patient experiences and outcomes in healthcare, but also racism and inequalities experienced by those working in the NHS system. Is that in England or across the UK?
That's predominantly in England, yes.
And I think the core work of the Race and Health Observatory is its research work, and I think that's twofold, both in relation to conducting or funding original research, but also a synthesis or review of the existing research and studies. Is that right?
That's correct.
We're going to look today, if we may, at the research work that the Observatory has undertaken in connection with COVID-19 and racial inequalities. And could we begin, please, with the rapid evidence review that was undertaken in March of 2021 in relation to pulse oximetry and racial bias? And I think you set out this in your witness statement. Can you help us, first of all, with what is a rapid review?
A rapid review is bringing together the existing evidence base around a particular area. It doesn't specify that a robust examination of the quality of that work is undertaken, but it brings together the evidence base that exists at that particular point in time.
So it's a way of reviewing and bringing together what exists in the research literature at that point in time.
That's correct.
And if we can cite this in the context of what was going on during the pandemic at that time, I think it's right that the COVID oximetry at home programme had been rolled out by NHS England in around November of 2020. And in December of 2020, there was an article published in the British Medical Journal about pulse oximetry and the potential for inaccurate readings in patients with darker skins, which itself referenced, I think, an American journal article. Was that the trigger for the rapid review that took place?
Those were the prime triggers, in addition to some anecdotal insights that we were getting from some medics around potential inaccuracies in this device.
And I think the rapid review identified a number of international studies going back as far as 1990, which identified the potential for inaccurate or variable readings from pulse oximeters used by non-white patients. Is that correct?
That's correct.
I think it's also right to say that the rapid review identified that there were some studies that found that the degree of pigmentation did not affect accuracy in the studies that they had undertaken. And at page 3, I think, of that rapid evidence review, it suggested a possible explanation for inaccuracies related to how those devices had been calibrated or tested. And it was suggested that it may have been that the devices had only been tested on white people. Is that correct?
That's correct. There's a fundamental point here, though, with regards to representation or a lack of representation in clinical trials that then leads on to the development or design of devices, medical devices, including pulse oximetry. Where there is a lack of representation, we often get products or devices that may not be suitable for the diverse populations that we're here to serve.
I think it's right to say that the studies that were referenced had largely been undertaken in America or internationally. And so this wasn't a review of the devices that were being used in England at that time, but I think the report concluded that more research was needed and it would be necessary to review the devices that were being used in the UK. Do you know if the recommendations made in that rapid evidence review were taken forward by the relevant bodies?
Yes, there were very clear recommendations in that review, and the ones that were taken forward included further research that was carried out. That a substantial bid was put out by the NIHR with regards to particularly evidence from the UK, and an update of the existing guidance around pulse oximeters and their usage on the NHS Choices website.
It was also suggested that the MRHA should undertake an urgent review of the pulse oximetry products used in the UK. Do you know whether the MRHA did conduct that review?
I believe an assessment was carried out in addition to the government announcing an independent review into equity with regards to all medical devices generally as well.
Thank you. I think after the Race and Health Observatory had published that rapid review in March 2021, the Observatory met with NHS England's Health Inequalities Improvement Team to discuss that report. And you've been provided with the witness statement of Stephen Powis of NHS England, who states that there were some concerns at that point within NHS England that the Race and Health Observatory report might potentially discourage some patients from ethnic minority backgrounds from participating in the COVID oximetry at home programme, and that this could further disadvantage those patients by limiting the tools available to clinicians in monitoring their progress or any deterioration if they had COVID-19. Is that something that was discussed between NHS England and the Race and Health Observatory at that time?
Yes, it was discussed and at great lengths. But I guess there were also concerns within the observatory that these devices could put people at risk, and the fact that the colour of your skin should not determine your chances of survival. And so where there were issues or doubts around a medical device, we thought it was absolutely critical that we highlight those, particularly during a pandemic that was affecting the level of oxygen in people's bodies.
Mr. Powis, in his witness statement, Professor Powis, I should say, states that subsequent to the publishing of the report, there were ongoing collaborative discussions between the Race and Health Observatory, the MRHA, and NHS England. Can I ask you this? Were the Race and Health Observatory satisfied with the engagement from NHS England on this issue?
Yes.
Thank you. It's also suggested that by Professor Powis that in hindsight it might have been more advantageous for the Race and Health Observatory report to have been shared with NHS England prior to publication, so that NHS England could have worked with the Observatory on sensitive and constructive messaging, including how to maximise potential benefits as well as minimising the risks. Can you help us, Professor Naqvi, with your views on that, bearing in mind also the timing of this review, which I appreciate was before the Race and Health Observatory had officially come into being?
Absolutely. This report was published in March 2021. The observatory was officially launched in April 2021. So we were doing as the title suggests, a rapid evidence review, which in fact took 6 weeks for us to pull together. In hindsight, it may have taken longer to arrange a meeting with NHS England to discuss the report. But the importance here was to get the information out and to highlight potential inaccuracies in the device. This wasn't about looking at the reputation of any individual or any individual organisation, but about potentially saving lives.
And in terms of now that the Race and Health Observatory is well established, if something similar was going to be done in relation to a review of evidence on a topic where NHS England, for example, are currently running a programme, how would that engagement, in terms of engagement prior to publication, how would that take place under your existing processes?
Sure. So that piece of work around oximetry was carried out during the period where the observatory was setting up its policies and its processes. The observatory now has well-established processes by which it engages in a proactive way with policy leads in various organisations that are relevant to the subject matter being looked at within any particular report.
So now that engagement would take place even prior to publication?
Absolutely.
Thank you. Can we move on, please, to look at the next piece of work that the Race and Health Observatory undertook during the pandemic period? That was, again, another rapid review that you set out at paragraph 9C of your witness statement, if that assists you, Professor Naqvi. I think in February 2022, a piece of work which reviewed a number of studies and surveys focused on inequalities in healthcare settings, and particularly for healthcare workers during the pandemic. And you've summarised the findings of that rapid evidence review in your witness statement. Essentially, it identified racial inequalities in a number of aspects, higher rates of COVID-19 infection rates amongst ethnic healthcare workers compared to white healthcare workers, less access to PPE for ethnic minority healthcare workers, and less access to properly fitting RPE, higher risk work roles allocated to healthcare workers in terms of risk of exposure to COVID-19 infection, and worse mental health and well-being, particularly in relation to symptoms of post-traumatic stress disorder, found amongst ethnic minority healthcare workers as opposed to white healthcare workers. And can I ask you this? In your view, were these racial inequalities that were identified in the studies synthesised in this rapid review a manifestation of structural or institutional racism in the NHS?
Well, it would be a combination of structural inequalities, the inequalities and structural racism that we see within society, how that plays out within, for example, the education system or the legal system or within healthcare, as well as the interpersonal racism that we see on an everyday basis, the trauma, the bullying and harassment, the what we call micro or macro aggressions, and how those two interact in terms of institutional racism, how that plays out in policies and processes within organisations, including, of course, our healthcare system.
Can you help us with this? What's the difference, if there is one, between institutional racism and structural racism? Because you mentioned both of those things in your answer.
So structural racism is about the structures of society, how they're organised to impact upon individuals or groups of individuals, and that may well be in relation to access to services or outcomes with regards to, for example, the education system, And institutional racism is more in relation to the everyday policies and processes that are looked at and used on an everyday basis in the NHS, for example. Then that may well be in relation to recruitment processes or disciplinary processes, etc.
Thank you. Staying with that rapid review report for now, I think at page 87 of that report there are a number of recommendations made, and I'd like to ask about one in particular, which was in relation to including more information in the national data sets, such as the NHS Workforce Race and Equality Standard. The recommendation was that all NHS staff in all sectors, including casually employed staff and those working in subcontracted services, should be represented in those data sets to present a comprehensive and accurate picture of workplace inequalities. Was that recommendation implemented, do you know?
I believe it was, and in fact, I think for the first time this year, NHS England published the Workforce Race Equality Standard for agency staff working in the NHS.
Thank you. Can we move on, please, to the Nuffield Elective Care Report? This was a joint report undertaken by the Observatory together with Nuffield Health in November of 2022. And you set this out at page 7 of your witness statement, if that assists, Professor, at paragraph 9E. I think this was a study based on statistical analysis of data from the hospital episode statistics, admitted patient care data, and it covered 3 years from March 2019 to February 2022. Is that right?
That's correct.
And I think that research looked at the data and the statistics to explore variation in treatment rates for routine hospital care, both before and during the pandemic, and looking at the changes in elective activity overall. And it identified 7 particular groups of common hospital procedures and 5 main ethnic groups of patients to see whether there was a variation according to ethnicity. Is that right?
That's correct.
You summarised that very helpfully in your witness statement. I think it's fair to say that there was considerable variation both between the ethnic groups and in relation to the different procedures that were considered. But there was a clear picture, I think, that emerged in relation to the Asian ethnic group. Is that right?
That's correct.
Can you summarise what that trend or picture was?
Well, I think the first thing to say is that there were pre-existing inequalities in elective care that kind of predated the pandemic. And that's one of the reasons why we need to focus on tackling ethnic inequalities in health on a continuous basis and not just when we're in an emergency situation as we were during COVID-19. But there's known epidemiology with regards to particularly the South Asian group having higher healthcare needs, and cardiac procedures is one example of that, which we highlight very clearly within that report. But there were other issues around the healthcare system moving towards remote consultations and digital care. And
before we move on to the causes of those disparities or the variation between the Asian ethnic group and the white ethnic group, I think the trend that was identified was that across all the different procedures that were looked at, the Asian ethnic group suffered a greater deficit in elective activity compared to any of the other ethnic groups, and particularly in relation to the white ethnic group. Is that correct?
That's correct.
And I think the report noted that if the proportional fall in activity during the pandemic was the same for the Asian group as that fall was for the white group, they would have expected to see just over 17,000 more elective procedures for the Asian group.
That's correct. I believe, yes.
And I think the report also found that those larger falls in activity for the Asian group occurred irrespective of regional differences in the impact of COVID-19, so infection rates in different geographical areas. And the conclusion was that the falls for that Asian group must have been largely related to changes in demand from that patient group.
That's correct.
And I think the authors then suggested some potential explanations for that. Could you assist us with that, please?
I think I mentioned the pre-existing backlog and known epidemiology, particularly amongst South Asian groups, but the digital exclusion point was highlighted in the report, and potential language barriers with regards to that. Private healthcare access was another point. We know that 41% of Asian households lived in the 10% most deprived areas, and therefore access to private healthcare may not have been an option for those patients. But looking at deprivation only tells you where an inequality exists, but not why it exists. And therefore, focusing on issues around the trust and confidence that communities and patients had with the NHS and with the healthcare system is an important point to keep in mind with regards to some of the potential reasons for why there may have been a decrease in elective procedures for that particular group.
I think the report also highlighted that it was possible that there may have been concerns about increased exposure to COVID-19 for the Asian group, leading to greater concern about coronavirus risk. And so choosing not to go ahead with elective procedures was a possible explanation. Is that right?
That's correct.
I think that report also highlighted some limitations in the statistical analysis that could be carried out because of the quality of ethnicity coding in hospital data sets. And I think you've identified that there are 3 principal issues with or problems with ethnicity coding. Could you help us with those, please, Professor?
Yeah. Poor ethnicity data recording in the NHS is a long-standing challenge that the healthcare system has. And in fact, the patchy data meant that the NHS was perhaps flying blind in its attempts to meet its moral and legal obligations. There are issues around the collection of data, ensuring that patients and the community know exactly why data is being collected in the first place, to build that level of trust and confidence. Secondly, around the quality of the data itself. So ascribing people to broad labels isn't helpful, particularly as we can see with regards to COVID-19 and the pandemic. It was having differential impact upon differential groupings.
So the ethnicity coding is currently too broad. There's a lack of granularity.
Absolutely.
So, for example, is there currently an ethnicity coding for Filipino ethnicity?
The codings that are generally used relate back to the census categories, and very often not the most current census categories. So there wouldn't be, in that instance, no.
I think there are 5 broad ethnicity groupings, is that correct?
I think there's more than 5 at the moment in terms of the census.
Thank you. Following on from that, one of the recommended actions of the Nuffield report was an urgent need to improve ethnicity coding to enable these kind of analyses. And it was identified that the Healthcare Quality Improvement Partnership should take a lead on implementation of that recommendation. Do you know whether that has been done?
I wouldn't know the answer to that, but what I do know is that there is a national drive, including within the Race and Health Observatory, to focus on improving ethnicity data recording going forward.
I'd like to ask now about the ongoing work of the Observatory related to COVID-19. I understand that the Race and Health Observatory have funded an ongoing longitudinal cohort study into the impact of long COVID on Black, Asian and ethnic minority healthcare workers. That's called the Reach Out study, is that correct?
That's correct.
I think no findings have been released yet. When is the final report expected?
Early 2025 will be the publication timeframe for the final study.
And also as part of your ongoing work, I think the Observatory have initiated a piece of work exploring the role of trust in interactions in primary care, and you set that out helpfully at paragraph 9F of your report. What's the nature of that work? Is it a study or a survey or?
It's a survey that was first distributed in January 2022, and responses were collected in April 2022. It's a survey of the public with regards to their views around accessing primary care and the levels of trust and confidence that they have with primary care.
And so is analysis undergoing at the moment in relation to that?
The analysis has taken place. We're just finalising the report, which we hope we can publish in the coming months.
Thank you. You've set out in your witness statement at paragraphs 10 to 18 some observations on the context of the unequal impacts of the pandemic, and that context being the pre-existing inequalities caused by structural racism. I'd like to ask you, if I may, about the example you give in paragraphs 13 and 14 of the different ways of analysing data, for example, the ONS data on mortality rates by ethnic group. You explained that when the Office of National Statistics published those statistics on COVID mortality rates, the data was presented with the rates adjusted for location, measures of disadvantage, occupation, living arrangements, and pre-existing health conditions. And the conclusion of the ONS was that this accounted for a large proportion, not all, but a large proportion of the excess COVID-19 mortality risk in most ethnic minority groups. Can you help us, please, with the view of the Race and Health Observatory on this statistical analysis and this adjusting of the mortality rates, and what's the impact of carrying out that adjustment?
Sure. I think there's a fundamental point around this, which is that those reasons highlight the causes of the inequalities, but not the causes of the inequalities. And what I mean by that is that at that time, we were informed of the reasons, as you've highlighted, being multi-generational households, comorbidities, ethnic minority, people more likely to work on the front line, including within the NHS. But what we weren't informed of was why that's the case. Why is it that ethnic minority staff are more likely to find themselves on the front line and less likely to find themselves in managerial positions or be able to progress within their field to that level? Why is it that they're more likely to live in multi-generational households and less likely to live in open space, green space environments? So focusing on some of the deep-seated issues around, for example, the ethnicity pay gap that happens within that occurs within society across institutions and organisations, is absolutely critical. So if we are to focus on surface level solutions to these deep-seated issues, we will be having kind of these conversations again in 5 years and 10 years' time, and not be on the front foot in terms of tackling these pandemics and these challenges in the future. Going back to your point around the ONS, I think it's important to note that those are experimental data, perhaps not as robust as data that's gone through a rigorous process, but also you can cut and analyze data in any way to tell any particular story. It's about having your moral compass pointing in the right direction so that you can really kind of focus on the issues at hand.
What you've said in your witness statement of paragraph 14 is that, talking about the way that the ONS data had been adjusted for those additional factors, that these statistical analyses, while useful, had the effect of moving the conversation on disparity away from conversations about the impact of structural racism. And it meant that the government's policy interventions at the time focused on the effects of structural racism, such as occupation and living conditions, without ever engaging with the causes of these inequalities, including racism itself.
Absolutely. I mean, racism has an impact on the effects that we then see play out in terms of, for example, in relation to the healthcare system, access and experience and outcomes. But racism also plays an impact on the social determinants of health as well, and that's housing and that's education, etc. So we must focus on the causes of the causes if we are to have permanent solutions to these challenges.
moving on, if we may, to the lessons learned which you've identified in your witness statement. You identify as a key lesson the need to view inequalities or disparities evident in the pandemic in the context of structural racism. Do you have any recommendations for addressing structural racism within healthcare settings, particularly to improve outcomes for ethnic minority healthcare workers?
Well, we heard so vividly during the pandemic from leaders, from government, from the NHS, pledges and commitments and promises to tackle ethnic and racial inequalities. Now, these were pre-existing inequalities for patients, communities, and the NHS workforce. But justice cannot be a fair weather commitment. We must focus on this issue on a continuous basis, and that means focusing on building and rebuilding levels of trust with our staff, NHS staff, with communities, and with patients. And trust is about truth told consistently over time. And when there's a breakdown in any part of that algorithm, there's a breakdown in trust, and there's a breakdown in levels of confidence that patients and communities and staff have. So building and rebuilding that level of trust is absolutely important. And that's about telling the truth about past failings, telling the truth about the reality of the causes of the inequalities. Is about consistency of action to tackle those causes of the causes. And it is about time and engagement that requires time, but engagement that's sustained and meaningful over time, and not piecemeal, as has been the case, I guess, in the past. And that's why having organisations that can hold up a mirror to the rest of the system, such as the Race and Health Observatory, to highlight issues that exist, is absolutely critical as we move forward. And of course, the NHS wasn't built to reflect inequality. It was built to remedy inequality, and that should be our aim and focus as we move forward.
Can I circle back, please, to the point you made about trust or lack of trust, both from ethnic minority healthcare workers and also the wider in the communities, ethnic minority communities. And you've highlighted in your witness statement a number of issues which emerged, which made it quite clear during the pandemic that there was this lack of trust between those communities and public organisations, public bodies, and the healthcare system as well. And you use the example of vaccine hesitancy and some of the concerns around that. Does that level of mistrust, particularly in relation to the healthcare system, appear to have increased during the pandemic, in your view? And if it has, what are the reasons for that?
Absolutely. I believe it did increase to a level which was reflected in the uptake rates of the vaccine, particularly amongst ethnic minority communities. I remember having my first vaccine within the Malcolm X Centre in the heart of St Paul's in Bristol, predominantly a multi-ethnic community, and it was the community leader stood at the gate of that community centre inviting people in. It was a trusted person in a trusted place. And it's about creating environments where people feel safe, people feel as though they have a level of engagement and trust with not just people, but places. And therefore having vaccination hubs within community centres, within places of worship, was absolutely critical, and utilising community leaders, community pharmacists, faith leaders, to pass on the message. The message is important, but so is the messenger. And having diversity in both was critical to build levels of trust during the pandemic.
Thank you for that example. Have you observed, Professor Naqvi, any successful initiatives or policies within healthcare settings that have made progress in reducing structural racism or the impacts of structural racism?
on patients or
Either patients or healthcare workers.
well, there's a number of initiatives that have stemmed out since the core period of the pandemic, and those include engagement with communities and the understanding that actually that engagement needs to be sustained and it needs to be meaningful as opposed to being focused on any particular project. So engagement with communities, but there's a lot more that needs to be done. Investment in local public health, investment in local communities and building that level of trust, investment in making sure that we have the adequate environments in our workplaces within the NHS for our ethnic minority staff with regards to their experiences within the workplace, reducing the bullying and harassment that we see and the gaps that we see between black, minority, ethnic and white staff, increasing the progress that we need with regards to opportunities for progression within the workplace. We need to focus on long-standing ethnicity pay gap review, particularly so within the NHS as well.
Those measures or recommendations obviously apply outside of a pandemic situation, but I'd like to ask whether you have any recommendations looking forward and to the potential for a future pandemic, whether you have any recommendations for the response of the healthcare system or planning for the response of the healthcare system in the event of a future pandemic to avoid that pandemic exacerbating the pre-existing inequalities that may well still exist at that future point.
I think the answer is probably in your question. These are pre-existing inequalities that require a concerted and focused approach. Our approach to addressing these inequalities must be continuous and must be deliberate and not reactive or temporary. Having a long-term focus on tackling racial and ethnic inequalities in health and health care is something that the government and the NHS should invest in and should focus on so that we're not on the back foot when it comes to any future pandemic, that we can tackle these issues and learn the lessons from previous situations and emergency situations rather than planning whilst we're in the eye of the storm.
Thank you. I have no more questions for you. I think
it's Mr. Thomas. Mr. Thomas sits behind you, Professor, but if you, by all means, look at Mr. Thomas while he's asking the question, but if you could make sure your replies go into the microphone, it'd be very grateful.
Good afternoon, Professor. Just a few questions I have. I should say I represent the Federation of Ethnic Minority Healthcare Organisations, and I ask questions on their behalf. I've only got a handful of questions. My first is this. In paragraph 14, you discussed the ONS report, which adjusted mortality data based on location, socioeconomic factors, occupation, and pre-existing health conditions. Here's my first question. Do you believe these adjustments accurately reflect the lived experiences and heightened risks faced by ethnic minority groups during the pandemic, or might certain aspects of their experience have been understated?
Well, those statistics provide a limited picture in the sense, as I've highlighted earlier, they present a picture of potential reasons and causes, but not the causes of the causes, not the underlying issues that then relate out in terms of the statistics that we see. And the other point is, of course, they cannot in any way reflect the lived experience of individuals. Behind every statistic is, of course, an individual and an individual's experiences with regards to that, which cannot come out in a figure or in any one statistic alone.
Secondly, in your opinion, how might future reports be improved to ensure that the full impact on ethnic minority groups is accurately reflected?
Well, there are a number of things here. One is for any change to happen, an organisation or individual must acknowledge that there's an issue to change. Without actually acknowledging that racism exists, we will not be able to move from the base. Secondly, qualitative data is great, is fine, it gives us information, but turning that information, that data into insight and that insight into action is something that we must, and organizations must focus on going forward. And that will include, yes, focusing on quantitative data and statistics, but also looking at the qualitative lived experience of individuals and communities and the NHS workforce.
Thank you. Thirdly, do you think that the adjustments made in the ONS report may have masked or minimised the true extent of the disparities in infection risk amongst ethnic minority healthcare workers?
Yes.
And if so, and you said yes, what aspects of the workforce's experience might have been overlooked, and what data points or considerations could have been included in the report to provide a clearer picture of infection risks for ethnic minority healthcare workers?
Well, there were a number of factors that were clear through what we were hearing and what we were observing at that time, including access to PPE or the lack of access to PPE, particularly for ethnic minority members of staff, with regards to protective equipment and the fit, with regards to risk assessments, with regards to a kind of a range of challenges and issues, and I guess dilemmas for the healthcare system that were not fully played out in some of those reports.
Let me come to my last question. In multivariable analysis, factors such as living in large households, frequent exposure to COVID-19 patients, working in emergency or inpatient ward settings, and serving as healthcare assistants are disproportionately present amongst Black, Asian and minority ethnic healthcare workers. Given this, firstly, do you think that these factors should be prioritised over others when addressing health inequalities and risk factors in healthcare workforce? And secondly, how can these occupational and social risk factors be better addressed in a future pandemic response to protect ethnic minority healthcare workers?
Well, I think the answer to both parts is probably related or the same. And it goes back to my earlier point around focusing on the causes of the inequalities. So looking at why is it the case that ethnic minority staff are more likely to find themselves on the front line, to be earning less, to be on the wrong end of an ethnicity pay gap? Why is it that they are therefore living in multi-generational households or in areas or spaces that do not have the quality of air, for example, that was highlighted in one of the reports that other groups, other ethnic groups have. So focusing in the here and the now with regards to some of those causes of the causes will hold the government and the NHS on a firm footing when it comes to any future pandemic.
Thank you. Thank you, milady.
Thank you, Mr. Thomas. Mr. Marquis? Oh, you're there.
Thank you, my lady.
Look behind the pillar.
I ask questions on behalf of the Frontline Migrant Health Workers Group. I have some questions on the ONS data that you've just been referring to, and that you've very helpfully agreed may have underrepresented the impact on ethnic minorities. Professor, first of all, can you confirm that that data set on which those statistics were based is linked to the census from 2011?
I believe so.
For the record, if you need confirmation of that, I'm not sure we need to bring it up, but it's INQ 302499 on page 1, which stresses that, if I can read it in, this data deals with estimates of differences in COVID-19 mortality risk by ethnic group for deaths occurring up to the 31st of March 2021 using linked data from the 2011 census. So it follows, Professor, doesn't it, that these ONS results do not include the deaths of any migrant who arrived after the 2011 census date?
Well, I assume they would be captured in some category, whether that's other ethnic group. I can't be certain about that, but there are limitations with regards to the census categories, as well as, of course, limitations to the data themselves, in the sense that they were kind of experimental data that were presented.
Well, Professor, I'm going to have to stop you for a moment, because your assumptions can, of course, be a little dangerous. I appreciate that comment. But if this data is based on census from 2011, it follows, doesn't it, that it cannot include people who were not on that census, i.e. those people that arrived after the 2011 census. It must follow.
Yes, I guess so.
Well, again, for the record, should there need to, we don't need to call this up, but should there need to be confirmation of this, INQ 89742 on page 21, which is one of Her Majesty's Government's quarterly reports on progress to address COVID-19 health inequalities. That document specifically states that any death of someone who arrived in England and Wales after the census would not be included in the ONS analysis. So having heard that, now you're aware of that, would you agree with my initial question that migrants who arrived after March 2011 would not be counted in that analysis?
Yes.
Thank you. Professor, we've also asked you to review an article from the Health Service Journal. For the record, again, that's 352887. Professor, this is an early pandemic article from April of 2020, dealing with the ethnic minority mortality rates in healthcare workers by Professor Cook and Dr. Linan. Have you had the opportunity of reading that before giving evidence today?
Yes.
Thank you. All of my questions really are on page 6. There are 3 key features of this research that I'm going to ask you to confirm from the research, of course. Mortality rates up until the 22nd of April 2020, 63% of the healthcare worker deaths were ethnic minority workers. Is that right, on the basis of this data?
That's correct.
Of that 63%, 83% at least were migrants. The figure there, if you've got it in front of you, it's actually 53 of the 64
That's
deaths.
correct. Yes.
But, of course, the status of the remaining 11 deaths was uncertain. So it's at least 83% were migrant. Would you agree with that?
That's correct. Yes.
If you can turn over onto page 7, we can see from the breakdown of national mortality rates that 36% of those migrant deaths were workers from the Philippines.
Yes.
And that is by far the highest national mortality rate for migrant health workers in that set of data.
That's correct.
So bearing in mind we have ONS data that lacks migrant mortality post-2011,
Yeah.
and we have early data that suggests very strongly, certainly in health workers, that migrants were bearing the brunt of the mortality. Would you agree that ethnic minority mortality rates could well have been significantly higher than those rates suggested by the ONS analysis?
That's correct, yes.
Thank you very much. 3 quick questions now. As far as you know, is there any official data in respect of migrant mortality rates?
Not that I know of, no.
Would you agree that that is a data gap that needs to be filled?
Yes, absolutely.
Thank you very much.
For a number of reasons, if I may add.
Yes, please.
With the influx of nurses, particularly in the NHS, coming from beyond Europe in particular, it's critical that it's critical that the NHS makes sure that the environments for those migrant staff are supportive, and that those individuals are engaged at all levels within the NHS.
Thank you, Professor. And final question. You've already told us when Counsel for the Inquiry was asking you questions that there's no inclusion of a Filipino category in equality monitoring in the current ONS. Would you agree that that exclusion also has to be remedied?
It would be beneficial to have as many categories as we can so that we can see trends and patterns in disease and in experiences over time.
Thank you, Professor, and thank you, my lady.
Thank you, Ms Markey. Professor, thank you very much indeed for your help. You've managed to make what for some people might be a dry subject obviously very informative and interesting. Thank you very much.
Thank you.
Right, I think it's Hans next.
Yes. My lady, if I may call Mr. Jonathan Rees.
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but
but the truth. Hello.
Hello, good afternoon, Mr. Rees. You should have your witness statement in front of you, and our reference for that is INQ 3049290. Mr. Rees, it's correct that you are a pharmacist, is that right?
That's correct.
And also a superintendent pharmacist for 2 independent family pharmacies.
That's correct.
And during the pandemic, you also held the role of country manager for Wales for the National Pharmacy Association, or NPA.
Correct.
You've described that role in your statement as representing the views of Welsh pharmacies to stakeholders on a UK level and ensuring NPA guidance remains appropriate for Welsh members. Is that an accurate summary of that role?
Yes.
Can you provide us with some examples as to how you gathered the views of Welsh pharmacies to fulfil that role?
Several methods, really. Obviously, during the pandemic, it was more difficult, but usually we would either have face-to-face meetings in the pharmacies or by phone calls, emails, or whichever technology we would care to use, really.
And so during the pandemic, did you mostly rely on that remote technology?
Almost 100%. Yeah,
Sorry.
almost 100%.
I'm grateful. And you've said in your statement that you heard, obviously, concerns and issues from pharmacists through that role. Can you provide some examples of the concerns or issues that you heard?
So the main issues would be revolving around staffing and skill mix to ensure when staff were unavailable due to infection or having to isolate, how to appropriately either acquire locum staff or how they can manage with the staff they have remaining, and also following guidelines in terms of things that are changing week to week or month to month, in terms of what is appropriate in how you run your business, and then also guidance on how they may apply for certain grants that were available at the time, or certainly maximise the contract that was available within pharmacy to ensure they're maximising the business potential.
And would you provide them with that information straight away, or would you take that back to the meeting, gather the information and then report it back to them?
It really did depend on the query. Many of them were repetitive, so I had the information to hand and we could just issue it. But if there was something more nuanced, then I may have to defer to some colleagues who would be sort of more learned in that area.
And how frequent were the meetings during the pandemic?
With
The MPA stakeholder meetings that you referred to?
Daily, yeah. So it's certainly earlier on we had a daily meeting before working hours, or very early in the working hours, to establish if anything had changed overnight or the following day, which I could then disseminate appropriately. But in terms of meetings with other stakeholders, it would be the frequency determined by them, but they were regular.
And when you raised issues or concerns at those stakeholder meetings, did you feel that your contributions were listened to, and did they lead to any changes?
Certainly, largely because the vast majority of people were reporting the same issues. It was balancing workload, the pressures involved, the staffing pressures. So myself or my CCA colleagues, we would all be reporting largely the same information back into whatever stakeholder we were reporting to at the time.
And when you say they all were saying the same, is that, can we take it from that it was across the UK, not just in Wales?
I would say I was only really exposed in terms of the meetings I had within Wales, but my MPA colleagues there were other regional managers across England who we'd all report into, but largely the issues were pretty much the same.
Thank you. And did you feel that role provided you with additional insight and resources during the pandemic that you might not otherwise have had access to had you not had that role?
Absolutely. Learning off of other people is a key part of developing, and having the ability to see, good ideas of how people are running their business certainly helped me in private enterprise.
I want to now move on to your role within your own pharmacy, if I may.
Sure.
You have, dealing first with the staff in your pharmacy, could you just set out for us what the makeup of staff was, the matrix, before the pandemic and then at the start?
Sure. So before the pandemic, there would be myself and my father as the pharmacist with a split week, pretty much. And then we have 2 checking technicians and then around 8 other members of staff plus a delivery driver. At the start of the pandemic, my father had to isolate, which meant my wife came back from maternity, who's also a pharmacist, so she took over his portion of the week while I worked for the MPA, and 2 other members of staff had to isolate. So then we took a decision with our workload, our team, to try and split into basically 2 teams within our pharmacy, with one coming in out of hours to try and complete the bulk of the dispensing work, leaving the team who works during the day to deal with patient phone calls, patient queries, and the patients that come through the door. So that was quite an efficient way of working.
And did you bring that in quite early on in the pandemic, that way of working, or did that develop?
Within the first 2 weeks or so.
Is that practice that you shared with others at those MPA meetings?
Yes, but it's quite difficult to replicate. We were fortunate, kind of the pharmacists we had within the family, and also the number of staff that we had who were available to work overtime, who lived very locally, and were happy to do it. So although we shared the information, it wasn't easily replicated.
And I think you've said in your statement that it was very frequent that you would be working overtime for long periods of time, up to many hours a day.
Pretty much every day.
Is it correct that you also brought on 2 pharmacy students to supplement your staff?
Yes, so they are the students who would have been working through us through holiday periods. They were advised by their universities to not work during the pandemic, to keep to their studies. But as all of their work was done remotely, they were happy to come in and work alongside us. And then the following year, we took on an additional student as well.
Was that through the apprentice scheme that you referred to in your statement?
No, that was a different member of staff again.
Okay, so you also brought on an apprentice through the government scheme, is that right?
Through the Kickstart scheme, yes.
And was that early on in the pandemic?
I believe that came in 2021, I think.
You have explained in your statement how the Welsh Government allowed pharmacies to close for up to 2 hours a day to process and dispense the increased volume of prescriptions, and you've described that as invaluable.
Yep.
In terms of what you would do during that period of time, could you just give us some insight as to what you would do?
Sure. So it basically allowed undisturbed dispensing. So there would be somebody labelling prescriptions, followed by somebody collecting those labels, attaching them to the relevant boxes, dispensing, and then finally to checking and bagging that prescription. Without patients coming through the door, the phone calls, that could be as a production line and done as efficiently as possible without interruption. I just meant the volume you can dispense like that is astronomical compared to having your doors open, trying to deal with patients. And it also allowed us time to clean and reset the pharmacy, order the stock that we need, because our phone lines were constantly in use from patient queries, meaning phoning out to wholesalers was difficult.
And it may be obvious, but to those of us that perhaps aren't as familiar with the back room of a pharmacy,
Sure.
How did that workload differ to before the pandemic?
So it was at least double for several weeks, and then was not far off that then for several months afterwards. And not only double in terms of the number of prescriptions through the door, but also the number of medications on those prescriptions, plus the dose frequency of them, or the dosing interval. So instead of supplying 1 month of medications, we were being asked to supply 3 months of medications, which then obviously meant that we needed to order triple the medication from our wholesaler, which takes longer to put away, to organise. Storage becomes an issue, so we're geared up for the volume. In an ideal world, your pharmacy remains at a pretty constant level. So trying to double or triple everything in a matter of days is very difficult to organise.
And do you think it was widely understood by members of the public why pharmacies had to close for that period of time during the day, during the pandemic, which obviously was different to before?
I believe so. Certainly where I'm based, the public were very accommodating to us, understood fully what we were trying to achieve, and that we were clearly working very hard to supply their medications. I'm aware of certain instances across Wales where that wasn't the case, or if patients didn't have the ability to return at a time where the pharmacy was then reopened, that could be difficult. But in terms of personal experience, our patients were wonderful with us.
And I think it's right, as you said, the National Pharmacy Association, in their statement to the inquiry, have referred to an increase in inappropriate behaviour from some members of the public due to frustration around waiting times increasing and the supply of medications, to the extent that some pharmacies had to recruit volunteers to act as security or introduce body cameras to protect their members of staff. So although you didn't experience that in your community, were you aware of that happening in other areas?
Yes, they did tend to be in more urban areas, but certainly even in localities close to where I'm based, that was happening, largely because some people were in queues for 2 to 3 hours, and then they would get to the front of the queue and the stock wouldn't be there. It inevitably led to frustration. But that's where, in our case, trying to do that dispensing overnight, we try to mitigate that as much as possible. But as I say, it's not always viable for everyone else to do likewise.
And I think you've said in your statement that that was also impacted by the reduction of in-person contact across primary care in general, so GPs, for example.
Yeah, so inevitably it meant, to use a phrase coined by the MPA, we did have to become quite literally the front door of the NHS. We were triaging patients that we wouldn't really otherwise see in a pharmacy environment. And we had no real control of those patients coming into us, whether they had COVID or not. It was impossible for us to ascertain that. But it just meant we were trying to direct those patients as best as we could to the most appropriate care provider at the time.
And was there guidance produced for pharmacists in order to help them with those changes in practice and care pathways?
Not particularly, because the variability of what you may see, the vast majority would be those we would refer back into our primary care colleagues for them to deal with either remotely or in person if it was that serious. But it's essentially just an extrapolation of the job we would do normally, just times, well, multiplied several times.
I want to ask you briefly about some feedback that the National Pharmacy Association received from discussions with its members during March and April 2020. So if we could please have on screen INQ 30340-104. So this is following extensive discussions and feedback. The MPA believes that the number of prescriptions dispensed went up 25 to 35% from February to March 2020. Home deliveries more than doubled, with some pharmacies reporting an increase of 300%. Phone calls to pharmacies more than tripled. Many pharmacies were experiencing long queues, and all pharmacies reported a big increase in working hours, often requiring the hiring of locum staff to meet workload. Some of those echo the experience that you had in your pharmacy. Were you aware of the other experiences that are expressed here also happening in Wales and across the UK if that came up in your MPA role?
Yeah, I would imagine almost every pharmacy would have the same story as this.
And did this level of demand continue throughout the pandemic?
Largely. Obviously, the initial flurry was noticeably different, but certainly up until kind of the autumn period, it remained very busy, and then winter pressures kicked in shortly after, which also sort of increased workload. And then we were into, obviously, vaccination season also, which was then difficult to manage on top.
Which actually brings me to my next question, which was whether you were involved in the vaccine rollout.
Yes, we were one of the first within Swansea to offer COVID vaccinations.
Did you receive any support from the government or public health bodies with that additional workload?
So the health board were very good at organising the patients, giving us the flow, the kind of the timetable for all the patients, and they were organising all of the appointments. And they were very good at that, to be fair. But that was kind of the limit of the input from them.
What measures did you implement locally to meet that additional workload?
So we had 4 vaccinators trained on site for ourselves. We, at that point, were able to incorporate the 2 teams into the same day, but we would have one sort of set of vaccinators and team organising those who were arriving for vaccines, and then the remainder of the team with the normal pharmacy functions. So we tried to separate the business into 2 within the same premises, so that the vaccinations didn't interfere with those coming for prescriptions.
Moving on to the topic of the supply of medicines and delivery of medication.
Yes.
You have described in your statement how before the pandemic you would be undertaking medicine deliveries approximately every 2.5 days a week, and that during the pandemic that increased to 6 days. Is that right?
Yes. Yeah, it was almost always, well, it was always 5 days a week and then 6 most weeks.
And is it also correct that that home delivery service is not funded, so your business had to absorb the costs of that?
That's correct.
How did you manage to meet that demand?
With difficulty, in all honesty. So one of the benefits of being a pretty small business is our agility and ability to respond. So in terms of as soon as we realised the demand was there, within 2 days we'd employed a new delivery driver. We were up and running 5 days a week, and then at pinch points up to 6. And then also on the weekends, my wife and I would be delivering ourselves to try and meet the demand.
And it's right, isn't it, that pharmacies were also asked to deliver medications to the shielded population?
Correct.
And the MPA have told the inquiry that they worked with the Welsh Government to enable software to support that delivery of medications. Did you benefit from that?
We didn't use it personally, but many within Wales did use that. Particularly for new patients, it allows you GPS tracking of where the medication is going, and it was largely rolled out for those using a volunteer system to deliver medication, so that they would know where to drop the medication. They could take a photo of where it was delivered, and as we weren't using signatures at the time, it allowed a time-stamped delivery of where that medication was left.
So did you benefit or use or make use of any other support that was available to you, financial or otherwise, to provide that additional service?
Not in terms of delivery, no.
And it's correct that there were shortages of medications early in the pandemic, which you've described as being partly due to a panic amongst patients. How did you in your pharmacy mitigate against those stock shortages, and can you provide some examples of the type of medications that were in short supply?
So the vast majority at that point were inhalers and asthmatics or COPD patients seeking to attain additional inhalers, and also paracetamol became an issue as well for quite a spell. So in terms of mitigation, what we would attempt to do is many prescriptions at that time were changed from 28-day prescribing intervals to 56 or 84. So we would firstly try to ensure that everybody received one, and then work our way from there if we had sufficient to give them the balance. Many patients, not many, but we did have incidences where we would issue medication to people and they would then turn around and say, well, I've already got 2 or 3, but I thought I'd better get an extra one, and that became a frustration, but there was no way to control that. You were just relying on patients being fair to their society, basically.
And the MPA also conducted a survey at the end of 2020 in November in regard to the medicine shortages. And at that time, it was reported that 50% of respondents were spending between 1 and 5 hours sorting medicines, and 40% were spending up to 10 hours, in some cases over 10 hours. Is that an experience that you had, or that you were aware of others having?
Yes, certainly some weeks were worse than others. We spent the majority of the first 6 weeks as the pandemic hit trying to open new accounts with new wholesalers to try and gain a wider access to the market as possible. So that took several hours to arrange. That's something that's not always available to a lot of pharmacies, particularly rural areas. They wouldn't be able to gain a new supplier. And also you have to meet minimum spend thresholds, which if you are quite a small supplier, you wouldn't be able to do. So trying to then manage your stock with limited supply is difficult. But we certainly spent many, many hours trying to find stock and then find it at a reasonable price also.
And I think you've also described how it was very time-consuming speaking to not only patients and trying to explain to them the situation, but also to GPs as well about alterations to prescriptions. So that was in addition to the workload, is that right?
That's correct, correct.
And the MPA have referred to the use of government-issued serious shortage protocols authorising pharmacists to supply alternative medicines if one was unavailable that had been prescribed. Were they used in Wales as well, to your knowledge?
At that time, they were the exact same, yes.
And did you use them?
It would be an automatic process. If that medication became an SSP, then it would automatically be relevant. And generally, those that fall into that category are used in pretty much every pharmacy.
And were they helpful in managing?
To a certain extent. So it allowed you then to know an increased price for which you could purchase the product for. And it gave you some... there was a tolerance then built into what you could pay, whereas otherwise you would be dispensing that at a loss, which basically means that the business is funding the supply of that medication to the patient, not the health service.
Okay. I want to move on to the topic of infection prevention control and PPE. You've said that there were multiple times when guidelines were unclear or Welsh guidelines differed from the UK. Can you provide some examples of when that occurred?
I was trying to think of some exact ones earlier, and they become hazy as time has gone on. A lot of the ones which stick in my mind were sort of distances people are allowed to travel. Certainly, as we moved through the pandemic, there was variation in how far you were allowed to leave from your location. So we cover an area which would go sort of nearly 10 miles sort of west and then likewise east. So those patients may not then feel confident that they are close enough to travel to us or leaving their immediate area. And also there were some discrepancies, I believe, in the social distancing requirements at various points as well. But for further examples, I would have to research a bit more.
That's okay, thank you. Was that discussed during the MPA stakeholder meetings that you attended?
Yes, yeah. So that would mean we would try to tailor the communications we would send across the 4 nations. We would try to tailor them appropriately for the nations, or to phrase them so that they may catch all.
And were there any problems implementing or interpreting national IPC guidance in the pharmacy setting? For example, physical distancing or the spaces between?
That was our biggest issue in terms of, I don't know how many pharmacy dispensaries you've been into, but they're generally quite small environments. So when you're trying to fit perhaps 6 people into areas that are quite small, maintaining that social distance is then an issue. And it's unreasonable to then be able to work in that environment with those distances. So trying to cut the number of staff there in the day is also difficult because you can't then manage the same workload. So finding that balance was an issue.
How did you try and achieve that balance?
By splitting the teams in 2.
Okay.
Yeah.
So were there any changes in the actual physical pharmacy pathway, so the way that you went in or anything
So
like that?
we taped areas off. So each section would be where somebody would. So if they were working at a computer station to label, then they would be within a certain taped area. If they were then dispensing for deliveries, they'd be in one area, or dispensing for collections in another area, to try and segregate you into a zone. It wasn't perfect because not everything within a pharmacy exists in that zone, but as best we could.
And I think the Welsh Government made available funding of £300 on the 1st of May 2020 to implement Perspex screens.
Yes.
Did you use that funding, or had you implemented them before that?
Yeah, it was an automatic payment that everybody received. So before then, we were already trying to segregate as best we could, and certain companies did offer the Perspex screens. They were generally more expensive than £300, but it was appreciated the effort.
And did community pharmacies in Wales have access to COVID-19 testing for staff?
Yes, it wasn't immediate. I don't believe that we were on the priority list, but it was fairly shortly after that we were included in that.
Can you recall when?
Not off the top of my head, unfortunately, but there was a period where if you did test, anyone in the pharmacy did test positive, that the entire team would need to isolate. But as we became part of the priority list, it meant that only that person had to isolate unless others tested positive.
Yes, I think the MPA have explained that in their statement, in fact, that the categorisation of community pharmacy initially as a retail setting
Yes.
Meant, so not healthcare,
Yeah.
meant that an entire pharmacy team had to self-isolate following one positive test in the pharmacy, and close contacts had
Yes.
to isolate as well. And so did that impact on your workforce?
Luckily, no, but I am aware of about 3 instances that I was covering in Wales where the pharmacies had to close for a period as a result of that.
Was that discussed during the MPA meetings that you attended?
Yes.
Can you recall when the change was implemented? It's not a problem if not.
No, sorry.
And you've said in your statement that during the first month of the pandemic, you had to source your own PPE as there was no access to the national supply. Is that right?
That's correct.
Could you perhaps just explain to us how you went about obtaining PPE during the early stages of the pandemic?
So the best offer we received at the time was from our one of the local comprehensive schools, where the design and technology teacher created their own plastic face masks, which they then issued to pharmacies locally. And you know, we applaud the effort. It was marvellous that someone put the effort in, but being what they weren't really conducive to wear for 8 hours in a day, or particularly fit for purpose, obviously, moving forward, but they were the best that we had at the time.
And I think you've described in your statement the inability of obtaining antiseptic hand gel during the early months as well, and resorting to creating your own product. Is that right?
Yes, it was the only real option at the time. So the WHO released their manufacturing of how to create your own hand gel. So we, my wife and I, we created our own for use for pharmacy staff and patients as they came in.
Did that continue throughout the pandemic?
No, we did that for about 2 months, and then I had a discussion with a local brewery who were interested in doing likewise. So I discussed with them how to proceed with that, and then we became their first wholesale customer, and they've done very well as a result. They now sell it in Harrods and places like that. So.
And when you did have access to the national supply of PPE, was that supply consistent and suitable for your staff?
So by the end of May into June, the Health Board had taken over the supply of PPE, where they would send a box a week of what you would need. And at that time, that was sufficient. You could request extra of certain particulars if you needed to. And from that point on, it was fairly well controlled.
I want to ask you some questions now about financial support from the Welsh Government. Did you experience or hear from MPA members about the financial impact on pharmacies, in particular any additional costs and expenses that were incurred during the pandemic?
Hugely. That was a large part of most conversations. So in terms of how pharmacy works, any work that we do, say, in this month, you're not paid until 3 months later, but your wholesaler bill is due 30 days later than today. So there's that gap between when we have to repay the wholesaler to when we actually get paid. In a general month, that's fine because you're constantly being paid for what you've previously done. But if your workload were to double or triple in a certain month, you need to be able to find that money within 30 days rather than wait for when you are reimbursed for the work that you've done. So that became a real issue for people sort of into April, start of May, before they got reimbursed then in June for what they had done.
And the Welsh Government in particular announced support for small Wales-based businesses. Did that provide any of relief during that period?
So there was an easily accessible £25,000 grant, which was very welcome at the time, because it was something that you could get hold of fairly quickly within a matter of 2 to 3 weeks, and had no real strings attached to it, which was excellent. And then there was also the COVID advance payment from Welsh Government, which gave you an average of your last 3 months NHS payments to be paid into your next monthly account, which I think came in the May payment of that
2020.
year. Yes.
Thank you. The inquiry understands that pharmacists did not initially have access to the government life assurance scheme, which was introduced for frontline staff. Was that the case in Wales as well?
Yes, that was the same.
And they were eventually included. Did you play any role in advocating for their inclusion?
No, so my MPA colleagues managed that on a UK-wide, well, England and Wales basis. I wasn't required on that. I fed in views from Wales, but broadly speaking, a lot of members, I don't think, had noted it at that time.
So I was going to ask you what was the impact on either your staff or members, but is it that there wasn't particularly an impact that you were aware of at the time?
Yeah, not noticeably. There was relief when they were incorporated because that became publicised, but it wasn't publicised initially that pharmacists weren't included. So unless they looked for the information, they wouldn't have known.
I see. And then the same was the case in terms of key worker status. Pharmacists weren't granted that. What impact did that have on your staff or MPA members that you were aware of?
So it meant delays or difficulty in basic items like food shopping, things like that became an issue. And just allowing extra time to be able to do that. And for certain members of staff, childcare was also a key component to allow your child to go into school or into a childcare facility whilst you worked was prohibitive to some of them working. Luckily, in terms of my personal staff, if one of the two would have been home to look after the staff at that time, to look after the child at that time, broadly.
You've described at the end of your statement the importance of pharmacies during a pandemic and how you had hundreds of new patients that you served during that period. Can you summarise that importance for us?
Yeah, with difficulty. I think the value of pharmacy prior to COVID, I don't think it was completely understood or realised by the population at large, how you have the ability to walk in to see a healthcare professional, to attain advice from trained staff and receive the medication that you need promptly. So having the focus on what pharmacy can offer has been very good for the sector on a public-facing level. But I think, as you can see from how we are dealt with nationally, that perhaps the workload that's involved is not realised in terms of revenue or profits, because since COVID, even though our workload has increased astronomically, you're still seeing 4 pharmacies a week closing, which is reflective of the revenue that you drive for the work that you do actually undertake.
And finally, this, Mr. Rees, can you describe for us the personal impact on you and your staff and any views of MPA members as well that the impact has had on you?
From a personal point of view, sort of led me to a love of pharmacy that I didn't quite realise I had before. I found great satisfaction in my job, which wasn't quite there before. Not that I disliked my job, but being able to serve the volume of people, to be able to help the new patients and be a reliable source of information for patients was quite, I don't know how to phrase it, but it was something that I'm quite proud of from our time there. The staff, likewise, the way we came together as a team, it's, we showed a resilience and an agility as a business to react to what is an unprecedented situation. And likewise across the network, the whole pharmacy network really did stand up to what was thrown at it. My concern is that moving forward, I'm not sure that same resilience will be there, purely from closures and fragility of the network. If it were to happen again, I'm not sure the pharmacy network would stand up quite as well as it did the first time.
Thank you. My lady, I don't have any further questions.
And I don't think there are any from...
There aren't.
No. Thank you very much indeed. I'm really grateful to you. I, for one, certainly appreciate the work that pharmacies, apart from the fact my brother was a pharmacist, so I probably ought to declare an interest. But you worked enormously hard to look after your local communities. So thank you very much indeed for everything that you did, for your colleagues around the UK did. And if I may say so, the area of Swansea seems to be very well served by you.
Great, thank you.
And did the family, I mean, you said your wife was on maternity leave, then you ended up taking her back to work?
Yes. So she came back from maternity early to cover the earlier part of the week while I worked for the MPA. In many ways, so it meant that I was working from home for the MPA, but also in charge of our 3 children, all of which were under 4.
Ah.
So in some ways, being in work was easier. It was a busy
I know that
time.
feeling as well.
Yeah.
Well, thank you very much indeed for all your help. I'm really grateful.
Thank you.
Right, that completes the evidence for this
it
week.
does,
that
my lady,
completes
yes.
part 1.
It does.
So congratulations to everybody for getting all the witnesses through. And I shall sit again in relation to this module on the 28th of October at 10:30.
I'm grateful.
Thank you.
All rise.